Welcome to AETCM, the Emergency Medicine Channel. A 68-year-old female presented to ER with complaints of right side deviation of face, ankle of mouth with inability to close her eyes, left side, since 3 days. On initial 10-second assessment, airway was patent, no pulling of secretion, breathing, respiratory rate was 16 per minute, saturation 98% on room air. Coming to circulation, BP was 160/80 millimeters of mercury, pulse rate 85 per minute. Disability, GCS was full, pupils were equally reacting to light, but there was the patient was not able to close the eye, left eye. And exposure, she was afebrile. So we had we had not taken any adjuvants since there is no history of any seizures or any altered behavior. Coming to history, a 68-year-old female who is a non-case of left CA breast post-mastectomy and chemotherapy 17 years back. She had history of facial deviation to right on 3 days back morning. She had, while waking up, she was having facial deviation to right, which was gradually progressing, and there is a drooling of saliva from the left side and inability to close the eye. She also complaining of some taste sensation differences in the tongue also. There is no history of any hemiparesis, any slurring of speech, any altered sensorium, any ear pain, ear discharge, or any rash over the body. So she was taken to nearby hospital. From there, they have taken an MRI brain, which was normal, and they started on steroids from there. And they, since the patient was not relieving, they came from the home to our hospital. So while examination, the patient was conscious oriented. There was on CNS examination, there was no wrinkles over the left side of the forehead, and the eyelids, means bell sign was positive. When we asked her to close the eyes, uprolling of the eyeball was seen, and the eyelid was not fully closed, even with effort. And there was facial deviation to right side. So left side element facial palsy was there. So our provisional diagnosis was Bell's palsy, left side.
Okay.
So lab parameters, CBC, CRP, everything was normal. No electrolyte imbalances was there. So we continued the steroids.
Blood sugar?
Blood sugars was 160. HbA1c was only 6.
Okay.
Not on any regular medicines. So we initiated on steroids and valsiclovir, 1 gram TID. And we had given a PMR consultation for facial exercises. And after 2 days, we discharged.
Okay. What are the immediate things you have to taken care in emergency room in facial palsy?
Initial steroids we can give to reduce the edema, and then the prevention of exposure keratitis, that if we have to assess the eye closure. If it is not done properly, we have to do eye padding.
Okay. What are the indications for MRI in facial nerve palsy?
If there are,
the MRI is already taken. So it is not required. That's why I'm asking.
If there is other focal neurological deficits, we can take, or if we find like it is upper motor neuron lesion.
Okay. What is this upper motor neuron cranial nerve lesion, 7th cranial nerve?
There will be upper part will be spared.
Upper motor neuron lesion.
Either a stroke in the cortical, or at the pondomedullary, pontine lesions.
Okay. What is the difference between cortical lesion and pontine lesion?
Cortical lesion will be dense hemiplegia, same side.
Hemiplegia will be there. Same side.
Cortical lesions, crossed hemiplegia will be there. And dense hemiplegia will be there in cortical lesions.
Suppose right-sided MCA territory infarct. You might have seen a lot of stroke cases. Which side will be weakness? Left. Which side will be facial weakness? Left. In pontine lesion?
It will be crossed hemiplegia.
That means
opposite side.
Opposite side weakness, same side facial nerve palsy. What are other cranial nerves come along with the facial nerve? Near to facial nerve nucleus.
The 6th nerve nucleus is there. That facial nucleus, facial nerve will wind around the 6th nucleus as facial colliculus.
Okay.
And then facial sensation, trigeminal nerve nucleus.
Why upper part is spared in this UMN facial palsy?
There
These are
will be
basic questions.
bilateral innervation is there for facial nerve for upper part.
Okay. That's why upper part is
Spared in one side.
Or is it relatively spared or completely spared?
Relatively.
Is it relatively spared or completely spared? You might have seen very severe stroke patients. In that case, the upper part is involved or not? Or upper part is not at all involved? Or
Completely spared.
complete upper part is relatively spared. That is very important because 50% of the connections are from opposite side, 50% of the connections are from the same side. That's why it is clearly written as it is relatively spared. Okay. So in severe UMN facial palsy, upper part can be involved. Okay. What are the reasons for LMN facial palsy?
Most common is viral HSV,
Bell's palsy.
Bell's palsy,
Okay.
then idiopathic,
Oh. Then
any trauma,
okay.
any that's stylomastoid foramen, any fractures.
Oh. Then any malignancies, tumors, which side, which area?
Pondometrium.
It's a big malignant oncology center. Parotid gland. Parotid gland malignancy, most of the time, facial nerves are either involved before the surgery or even after the surgery, sometimes it can be involved. What will happen to the taste in facial nerve palsy? LMN facial palsy.
Sensation will be lost.
Taste sensation will be lost. Okay, what are the tastes will be lost?
From the
Okay, anterior two-third will be lost. What are the other reasons for facial nerve palsy, LMN type of facial palsy, other than what you told now? It's not very common, but you can see sometimes here.
snake bite.
Snake bite, what type of palsy you get? What type of facial palsy you get?
LMN.
It is not facial nerve palsy. It's a palsy of all the cranial nerves, including facial nerve. That's all. Okay, but there are some conditions where facial nerve is involved one side. Here you have to check properly. What is that condition? Ramsay-Hunt syndrome. What is that? We had
Herpes
recently
simplex.
one case here.
Herpes simplex virus
So
infection. So it will be
lesion-
rash over the
Rash over the.
pinna and external
Okay. How do you differentiate between LMN and UMN facial palsy? These are basic questions. I'm only asking facial nerve palsy. What is there to ask? How do you differentiate LMN and UMN facial palsy?
element. Whole side will be hemifacial palsy will be there. UMN mostly only lower side, that facial. Upper side will be.
Then upper part will be.
Bell sign will be negative.
Bell sign will be.
Negative in IUMN.
Bell sign will be will not be seen.
Seen
Okay. Negative means prowling is not there.
There will be
So it
no
will not
bell
be
sign.
seen. Then taste.
Taste sensation. No. Bilateral it will be. Means in both it will be closed.
Human facial palsy. Taste is a separate nerve, but it comes along with the facial nerve. That's all. Centers are different. So in a human facial palsy, taste will not be affected at all. But whereas LMN facial palsy, it comes as a group. Okay, so it can be affected. Okay, what is mimic palsy? Mimic palsy.
Seen in Parkinson's.
Parkinson's. They mimic like facial nerve, bilateral facial nerve palsy will be there. What is the difference between bilateral UMN and bilateral LMN facial palsy? How do you differentiate? Bilateral UMN and bilateral LMN facial palsy. Can we get like that? Can you get like that? Bilateral LMN is very common because there are conditions, infiltrative diseases, sarcoidosis, all these things you can get, syphilis. So you can get all these things. But how do you differentiate that bilateral LMN facial palsy, bilateral UMN facial palsy? Emotions? Emotions are seen in which condition?
UMN.
UMN or LMN?
UMN.
Emotions are preserved in UMN,
lesions.
bilateral UMN facial palsy, whereas emotions are even absent in bilateral LMN facial palsy. Parkinsonism?
Face.
Emotions? Most of the time, emotions are reduced. Okay. Now, how do you like after this like acute problem? How do you proceed? Whether the patient improves immediately or it takes time?
No, it will take 4 to 6 weeks. 4 weeks we have to continue for the facial exercises.
Okay.
In 4 to 6 weeks only recovery will be there.
Okay. Can GB syndrome present like this? Can you get or not?
Yes.
What is that condition called as?
Miller-Fisher.
Miller-Fisher variant. What is that Miller-Fisher variant?
Will be cranial nerve ophthalmoplegia, facial nerve palsy, and
It is bilateral element facial nerve palsy with ophthalmoplegia, then descending type
paralysis.
of paralysis. What are the other conditions which can mimic this Miller-Fisher variant of GBS? GBS is nowadays, it is very common, including our state. So Miller-Fisher variant is only a type of palsy where the cranial nerves are involved first, including facial nerve bilaterally. What are the other conditions which can? Snake bite. One is snake bite. Then botulinum toxicity. One more. Tick paralysis. These are the common conditions where you get descending type of weakness where the facial nerves are involved first. Okay, so that is very important. Okay, what happened to this patient afterwards?
We had started on valsiclovir and steroids, and we had done kept a PMR consultation. They were doing the orofacial exercises,
Okay.
and we discharged to and advised to continue the PMR exercises.
Okay.
Models.
What else you read about this case?
Sir, the Bell's palsy actually management, it depends on the degrees of the facial nerve palsy.
Okay.
So it is divided, it is had a classification, House-Brackman classification, that is from 1 to 6. 1 is normal, and every classification, that 2 is mild dysfunction, 3 moderate, moderately severe, severe and total paralysis. Every classification have gross and motion abnormalities. So with mild dysfunction, the mainly motion with is the eye closure will be complete closure with minimum effort, and the mouth will be slightly asymmetry. And moderate, it will be complete closure with effort, and mouth will be slightly weak with maximum effort. Moderately severe, eye will be incomplete closure, and the mouth will be asymmetric with the maximum effort. And severe, there will be incomplete closure of eyes, and there is slight movement of the mouth and total paralysis. So according to this House-Brackman classification, grade 1 to 4, 1 to 3 early oral steroids should be given, and 4 to 6 steroids with acyclovir or valsiclovir should be given.
Okay.
And then wait for 4 weeks for complete recovery, or to see whether there is a recovery.
A lot of brainstem syndromes are there. You're supposed to read all these things. Brainstem syndromes where facial nerve can be a part of the syndrome. Okay, so that also you have to read. Okay, what else you want to tell? Nothing. Okay.